We are on live now. Okay.
Okay. Can we mute everyone, Dr. Maninder?
Yeah, okay. I'll see. Mute. Okay, so we are live now on YouTube.
Okay, that's great. So they can see the review. All are here. Welcome, Dr. Sharad. How are you?
Thank you. Thank you, Dr. Vineet.
Hello, sir. Hello, Dr. Sharad. How are you?
Jain, good afternoon.
Hi, Sharad. How are you?
I'm fine, sir. Dr. Rehan, good afternoon.
Sir. How are you? Long time.
Okay. How is Bhopal doing?
All is fine, sir.
So, sir, with your permission, Jain sir is also ready. So, shall we start, sir?
Yes,
it's already live.
Please.
Yeah.
So, I think.
So, good afternoon, everybody, and thanks very much for giving me this opportunity to talk to the students. I think I do not know how many of the students are first year, second year, and third year, but I think I would just give one sentence that whenever you start preparing for your learning process in orthopedics, I would say you should develop your checklist, how in that order you have to examine any case. And that is more important when you are dealing with a spine case, because there is a huge number of steps to be taken, so that you learn to examine the patient in those right steps, and you are able to, and you're not able to miss out certain important findings to be elicited. And that is why, and that's why it's important. And then you practice on a patient on those sequence from the checklist. And I'm sure if you just do it for 1 year, 2 year, by the time your exam come, you are perfect in examining a case, any patient, and more so for a spine. So I'm just talking about how to approach a case of spine. And the objective is that we need to identify physical manifestation of problem, understand the root cause, and treat for successful outcome. That's the objective of looking at any patient. Now, while evaluating a patient, you need to know the patient details and the chief complaint. And in case of spine, generally they are pain in back, weakness or deformity, one alone or together. And then you elicit on these chief complaints by having a detailed history, and then go on to past history, family history, drug histories, and social history. Now, these are not just mere formalities. These are just has an important bearing. And that is what that for an age, spondylolysis is common in adolescent, while disc pathology is more common in adults. Back pain in children is more common because of infection or tumor or inflammatory pathology like angstpond or rheumatoid arthritis, while elderly populations, they generally have back pain because of spinal stenosis, that is degenerative. Similarly, for sex, adolescent idiopathic scoliosis more common in females, while certain disease like myeloma, lymphoma, and eosinophilic granuloma, they have a male preponderance. Osteoporosis common in Asian women and Caucasians, and there are certain occupation-related clinical problem as well. So the chief complaint in a case of spine starts with pain in neck, which may go to upper, mid, and lower back, whole of the back. Weakness maybe of upper limb, lower limb, or all four limb. There may be a specific complaint of loss of sensation, loss of control of urine and stool, deformity of the back, difficulty in walking, and a swelling in the back. So these are general chief complaints, but then back pain remains the most common, because back pain is an industry in itself. And there is a huge, tremendous treatment cost has been spent every day and every year in the world. And it is second to upper respiratory tract infection as the cause of absence from the work. And not only that, it is a cause for unnecessary surgery as well. And McNabb, such an old book, in his one of the pages, it's written that more spine surgeries are done in the West Coast than in the East Coast, and not because the West Coast have a weaker spine, but it is because they have a more spine surgeons. Well, MRI has certainly compounded the problem, because it has increased the indication of surgery by looking at the MRI picture. However, and that is what the role of clinician to define whether this observation on MRI has anything to do with the patient problem or not. But certainly it has made surgery predictable. And now back pain is a challenge because definitive diagnosis is difficult and not made in almost 85% instances. Our objective is to distinguish benign, self-limiting conditions, which are 95%, from 5% serious diseases. And not only that, we have to ascertain emergent problem likely to come up in particular patient, which may be a neural deficit, which may be a spinal deformity. And we need to determine when imaging is needed and when intervention is needed. And we need to reassure the patient that, yes, what is going to be the outcome. So first of all, various causes of pain, they may arise from vertebrae, disc, facets, neural structure, muscles, ligaments, vascular structures. And hence they are categorized as spondylogenic, neurogenic, muscular, viscerogenic, vascular, and psychogenic. And these terms are self-explanatory. When all present with pain, but there are certain characteristic features which differentiate one type of pain from other. Onset of pain, how it has commenced, how it has progressed, what is the site and nature, whether it is localized, diffuse, what is the timing, whether it is with rest or with activity, what are the aggravating and relieving factor, is there a radiation or a back pain only, and what are the if there is a claudication, whether neurogenic or vascular claudications. So the pain in each type on these heads, one can differentiate whether it is a spondylogenic, neurogenic, muscular, viscerogenic, vascular, what kind of pain it is. And this is what is the pain analysis. What is the site of pain? If it is in the neck, is it upper back, mid back, lower back, whether it is localized, diffuse, or radiating. If it is onset, then is it a sudden onset, which may happen in fracture or heavy lifting, or it is a gradual onset in infection, inflammatory diseases, and tumor. What is the character? It is constant, pain at rest, intermittent, or it is sharp, dull aching, burning. Is it radiating pain or referred pain or radicular pain? If it is associated with associated symptom like sensory symptom, paresthesia, weakness, urinary involvement, fever, weight loss, early morning stiffness, and muscle spasm. Well, according to time, if it is less than 6 weeks, then it is generally called as acute pain, subacute 6 weeks to 3 months, and chronic more than 3 months. And course may be worsening, improving, and fluctuating. When there is a long pain, it is important, worthwhile to know whether it is worsening, improving, or fluctuating. What are the exacerbating and relieving factors? Say sneezing or coughing, as generally happen in a disc disease, worse at night in TB and malignancy, physical activity, osteoarthrosis and fractures, relieving factor, physical activity in angst or maybe relieving with certain analgesic. And then the pain must be evaluated on the severity scale of 0 to 10 as a VAS score. Now, there are certain red flags for a particular type of pain which should not be missed. So for a cancer, if someone who had a history of cancer has a persistent pain for more than 1 month and with an unexplained weight loss, particularly in a patient of more than 50 years, then these are the red flags for pain not to be missed for cancer. For infection, yes, if someone is a drug abuser or patient has an active or recent infection elsewhere, or patient is on immune suppression or a diabetic, then probably the possibility of a pyogenic infections are more. While for tuberculosis, persistent localized pain with or without constitution in endemic lesion is the red flag for tuberculosis. Well, for fractures, anyone
खड़े जाएगा मैं कम से कम अरे वकील साहब सॉरी प्रैक्टिस के लिए कह रहा हूँ यार ये पहले भी नहीं किया फिर
noise somewhere. So for fractures, anyone more than 50 years of age, particularly on a corticosteroid or a known osteopenia or osteoporosis, and if has a major trauma, then probably these are the red flags for a pain because of fractures. And in elderly patients, even minor trauma is good enough to cause a fracture. And similarly for neurologic issues, progressive radiculopathy, myelopathy, urinary retention, progressive motor weakness, sensory alteration, and changes in bladder, bowel, and sexual function. These are the red flags for neurologic causes. Now, pains are of various types. Axial pains are those which are at each segment of spine, or other which may arise from other soft tissue structure, vascular, but it is at the each segment of spine, or a visceral or a radicular. So axillary pain occur at each segment of spine, which worsens with certain activity like sport, or with certain position, sitting for a long period, and which relieves with rest. These are generally axial and non-mechanical pain, and they are related to degenerative condition of the spine. While radiating pain may be for upper limb, back, from back to neck and upper limb, or lower back to lower limb, maybe in cervical, thoracic, and lumbar region. They may arise from vertebral disease, disc, or degeneration, or a space occupying lesion of the spine, or any disease of the spinal cord and nerve, say, for example, is a herpes zoster. So these are the conditions which give rise to radiating pain. Now, so radiating pain could be because of spine-related issues, maybe disc degenerative, space-occupying lesion, or a spinal cord and nerve root-related issues. And depending on the cervical, thoracic, and lumbar, it could be of any location. Now, one is a claudication pain, and that claudication pain is a pain which appears, which comes on walking and relieves with the rest. And so these are of two types: vascular claudication and neurogenic claudication. And the simple cause is impaired blood flow to the legs is a cause of vascular claudication. An example is Burgess disease, or some thrombotic or lumen narrowing of the blood vessel because of atheroma, or neurogenic claudication may be because of lumbar canal stenosis. Now, there is a difference in the character. Vascular claudication, they usually starts below the knee, and if you continue to walk, then pain increases up. While in a neurogenic claudication, generally symptoms start from the back, from the both sides of the buttocks, and then going to the back side of thigh and to the knee and to the below, and they are generally associated with paresthesia. And now there are certain aggravating and relieving factors. So vascular claudication, if patients is allowed to stand for a while and walking is stopped, they are generally relieved. While neurogenic claudication, they don't get relieved. Just a minute. They are relieved, triggered by standing, relieved by sitting, and comfortable with climbing while the pain increases while coming down the stair. Because in all those conditions where the lumbar spine is hyperextended, the pain increases, because in the hyperextension, patient have a gradual, little narrowing of the spinal canal because of infolding of ligamentum flavum. And that is what is the positive shopping cart sign, where person is comfortable in moving the material with, in a shopping cart with bending forward. And that is why these patients, when you ask them to climb up, they feel pain. When you ask them to come down, they are relieved, because in all such positions, they walk bending forward. So all those conditions which all those work which are done with bending forward, they do not have pain. However, any hyperextension or any standing, their pain is aggravated. Now, categorization of pain. So I said radicular pain, nerve is actually irritated. Claudication pain because of neurogenic and vascular. And there are certain non-mechanical pain which are inflammatory, which aggravates after rest and improves with activity and disappear after some time. Now, there are many situations when your description of the patient does not take you anywhere and you are confused as far as the categorization of pain is concerned. So it is not a bad idea to give them a drawing like this and ask them to draw the pain, location of pain on these pictures, and depending on the severity. So all those patients who have this kind of picture, it looks a confused patient as far as description of pain. And such are the pain drawings are observed in psychogenic or psychogenic cause of back pain. Now, after history, we move on to examination of spine. And because in the history, we have been able to understand that probably patient has a mechanical pain, or patient has a degenerative pain, or patient has a metabolic cause of pain, or a tumor, or an infection. This broad categorization should take place after the history, and one should be able to understand whether which part of the spine is affected, whether it is cervical, dorsal, or lumbar. Now, then we move on to examination of spine, and the prerequisite is a full exposure of the patient, and examination has to be done in standing, sitting, and lying position. However, if patient has a paraplegia or quadriplegia or impending quadriplegia or some neural deficit, Such patients should not be examined in standing and sitting position. They should be examined in lying position, either supine or guarded rolling lateral position. Now you need to inspect from the front, back, and from the front, side, and back for skin, any discoloration, any swelling, dilated veins, sinuses, cafe au lait spots, tuft of hair, dimple and nevus, vesicle along single dermatomes, and evidence of infection anywhere in the body. I think here I would, rest of the things are self-explanatory, but I would like to put a minute on the cafe au lait spot. Cafe au lait spot are the forerunner for a neurofibromatosis. And in that case, if any cafe au lait spot of 5 centimeter and more, single cafe au lait spot, it should be taken, it is significant. However, if these are smaller cafe au lait spot, 1 centimeter and more, then 5 are taken as significant. And in children, it is 2.5 centimeter for single and 0.5 centimeter for single, smaller cafe au lait spot. Now, we need to inspect any deformity, any step which is visible, or a postural changes in frontal, coronal, and sagittal plane. Need to look at the position of head, whether it is straight or tilted onto the one side. Need to see the hairline, because there are certain conditions where there is a low-lying hairline like Klippel-Feil anomaly. Level of shoulder, you could see here, these shoulder level are different. Level of scapula are the level of shoulder. Here it is different, and even this in scoliosis, when the spine is not balanced, then level of shoulders are different. Level of scapula, level of iliac crest, if it is equally symmetrically placed. What is the spinal curvature, if you are able to see, if it is a normal curvature, and landmarks, and paraspinal muscle spasm, if it is visible. And in a paraspinal muscle spasm, when the muscles are in spasm, one sees a deep central furrow. Look for any bulge anywhere. Look for any fullness below the iliac crest, above the iliac crest, and distances between the 12th rib and iliac crest on both sides. From the front, if there is a torticollis, when neck is turned onto the one side and tilted, list, the whole torso is turned, bent at one point, and that is the list. For a deformity, for a scoliotic deformity, look at the site of the deformity. Look at whether there is a 1 curve, 2 curve, what is the bigger curve, what are the limits of curve, and if it is associated with kyphosis or not, and if there is any repercussion on the chest, if there is a chest deformity, and if there is a costopelvic asymmetry. So in a scoliotic patient, when the patient is standing by the side, there is always a big gap between the arm and the side of the body. In a kyphotic in the concavity, while in convexity it is near, there is hardly any gap or very little gap. Changes balance of the spine, one can look at the occipital prominence and see whether if a plumb line is dropped, is it passing through the natal cleft or onto the one side. So that gives a idea about the balance of spine. So you can look, you can inspect, you can observe, and then you can do all these things in palpation as well. For scoliosis, there could be two kinds of scoliosis. One is a fixed scoliosis, which does not change with sitting, and on forward bending, it remains the same. And on side bending also, the curve remains, it doesn't disappear. And if there is a deformity, scoliotic deformity in dorsal spine, then a rib hump is visible onto the one side. Because in a fixed structural scoliosis, vertebral body is rotated on towards the convex side, and hence the rib on that side has a more posterior origin, and it has to come anterior to the sternum, and that is why rib hump, it becomes a prominent angle of the ribs, and that is at multiple level, it becomes a rib hump. So you could see here the bending forward, since there is a convexity here, this rib hump is visible in a structural scoliosis. While scoliosis secondary to sciatica or a prolapse disc or any other hip pathology, then they generally have a diffuse curve. There is no rib hump because there is no rotation of vertebral body. On forward flexion, curve changes, disappears on recumbency. Say scoliosis secondary to hip pathology, if flexion deformity or if any other abduction adduction deformities are obliterated, or patient is made to sit and lie down, where abduction, pelvis is square, then scoliosis disappears. In a sciatic scoliosis, forward flexion generally is limited because it induces the SLR, irritation of the nerve. Now, postural scoliosis, which is correctable on bending forward, and short limb scoliosis, once correctable on sitting or when the shortness of a limb is eliminated. Now, you need to inspect from the side. This is the normal curvature, and you could see this is kyphotic curvature and hyperlordotic cervical spine. You could see the flattened lumbar spine in a spondylolisthesis, or maybe a prominent dorsal spine lower in a Scheuermann kyphosis. So this all need to be inspected from the lateral position. And this is what I was meaning is that is a diffuse kyphosis, which will produce a compensatory cervical lordosis. You could see any kyphotic deformity, whether mild, moderate, and severe on the inspection and confirm on the palpation. You could see a diffuse kyphosis in dorsal lumbar region. And as a result of that, this 12th rib has come very near to the iliac crest. So there may be a costopelvic impingement. And this is the lumbar kyphosis. So you could see the curvature in a severe lumbar kyphosis as a result of a severe lumbar canal stenosis. Patient is bent forward. So these changes in the posture one can observe from the lateral position. Now this is a pot belly, protuberant, increased lumbar lordosis. So this need to be from, you can see from the normal. Again here, flattened lumbar spine as a result of spondylolisthesis. Now these all findings need to be observed, palpated as well. But then most other important thing is increase in the temperature, and that you can palpate wherever there is a localized finding onto the spine, whether there is an increased temperature as well. Prominence or depression in any part of the spine need to be palpated. Pulsate, if there is any pulsation anywhere. Central froze, I have already told that you can palpate. And prominence of or the spinous process, you need to palpate the spinous process from top to bottom. And the best way is that take your middle finger onto the spinous process and two finger on both sides and keep on moving gently on the whole of the spine. So even if any spinous process is prominent, then that your finger will be able to appreciate. Any swelling anywhere in the back, need to examine whether it is a cystic swelling or a solid swelling as we examine any swelling. Now, tenderness of the elicitation of tenderness has a definitive methods, that whenever you have to elicit the tenderness, you palpate on both sides of spinous process by direct pressure, not onto the spinous process, because spinous process is a bony prominence just under the skin. As you press it, person may wince. So you have to press on both sides of spinous process for direct pressure to elicit any tenderness in the any condition, any disease underneath. If it doesn't elicit tenderness on direct pressure, one can even twist the spinous process and then give a little rotatory stress onto the vertebral body. If even it is not there, then sometime you can give a deep, gentle thrust. Make sure that you are not dealing with a case of infective disease or a destructive disease when you are doing a deep thrust tenderness. Well, anvil stress and percussion, they are generally not done, but anvil stress is some when everything is normal and there is no destructive disease, then one can do an anvil test, just give a thump onto the head if there is any tendency. But this test is generally not to be practiced. I'm getting sound in between. I do not know what this sound is. Now, this is what is the paraspinal muscle spasm. And here you palpate and you find that these muscles are firmer than the muscle above and below. So you have palpated spasm, spinous process, as I said, Holzwarth test. Paravertebral muscles, I've already told. Deformity steps, you have to palpate what kind of deformity, what kind of steps, any swelling, and other bony structure. Now, then we come to movement. Now, we have to realize that this movement of the spine is different than the other joint, because here the movement, it's a composite movement of the whole spine. All movement occurring as a composite cervical spine or a dorsal spine or a lumbar spine or a whole spine. So elicitation of movement is little difficult. Say, for example, in this cervical spine, you have to make patient sit tucked onto the chair so that your dorsal spine is immobilized. And then you ask the patient to bend neck forward and backward. Then only neck movement could be understood. And now here it is a forward flexion, extension. Now we need to know that this is a composite movement, 70-80 degree movement occurring at the from C1 to C7. Now sideward again, it is generally 80 degree. Out of that, almost 30 to 35 degree occurs at C1, C2, and remaining as a composite movement of the remaining segment of spine. Similarly, side bending. So these are a composite movement, and that need to be done gently and compared. Dorsal spine does not have a big forward flexion and extension, maybe slight twisting, side bending motion. But lumbar spine, when you ask the patient to bend forward and the whole spine, then generally we find that hand or finger reaches within 6 to 7 centimeters from the floor. And that is what is a normal lumbar motion. And this is what normally it should reach about 6 to 7 centimeters up to the floor. And if it reaches up to that, then it is a normal. However, someone who has a tight hamstring, then this may be difficult. This is what is the extension elicitation. Hold the iliac crest, ask the patient to bend forward, twist right side or left side to see the rotatory movement of the lumbar spine, or a side bending. Generally, it goes to mid of the thigh. And that's what you compare with the other side. So that's how the lumbar spine movement is tested. Now, there are certain tests, Schauber's test or a modified Schauber's test, which is done for isolated lumbar spine. Here, you take posterior superior iliac spine on both sides, draw a line, take it 10 centimeter, 15 centimeter above, ask the patient to bend forward. Generally, this measurement increases by 4 to 5 centimeter, and that is the Schauber's test. Now here, posterior superior iliac spine, 5 centimeter below, 10 centimeter above, and this marks, and then when it's about generally 5 centimeter, it increases. And if it increases by 5 centimeter, then it is a normal lumbar spine motion. Chest expansion is to be measured at the level of nipple. And there are certain conditions where you have to take the measurement, deep inspiration and deep expiration, and the difference in the two. And generally it is about 5 centimeter in or more in adult persons. Now, no examination of spine is complete if you do not examine sacroiliac joint. So you need to do an active SLR, compression test, distraction test, and there are certain rotation tests, either pump handle, Gensler's and Laker's test. We all know that these sacroiliac joint, they are obliquely placed joint, and hence these are special tests. So we have to, by these tests, we have to stress the sacroiliac joint to elicit the pain. And this is what a compression test, distraction test, where we are distracting the sacroiliac joint, or maybe you are flexing the hip and taking the shoulder to the other side to give a rotatory strain onto the sacroiliac joint, or a hyperextension of this limb. So these are the various tests which should be done for a sacroiliac joint findings, because there are lower lumbar spine and sacroiliac joint involvement. Sometime one may get confused. These measurements generally not practiced, but they should be symmetrical from occipital protuberance to the iliac crest. It is again C7 to 30 centimeter down below. You measure it and you ask the person to bend forward. It should increase by 3 to 4 centimeter. So these are general measurement for general involvement of the spine, but generally not done in the practice. Now, I think I would like to stress on auscultation. Generally, orthopedic surgeons, they don't like stethoscope with them. However, when your pain is not characteristic and your history, pain, and your finding are not taking you to any diagnosis, then sometimes you are looking for some pain which does not fit into all orthopedic conditions. And it has happened 2 times with me when I auscultated. Those 2 cases in last 30 years were of aortic aneurysm, one of a tubercular origin. I think that one of my publication as that aortic aneurysm. So auscultation, yes, one should know that sometimes these sounds from the aneurysm or some vascular tumor, they are audible. Now there are certain special tests for cervical spine, for lumbar spine, and these tests are for disc diseases, and hence these tests only to be done, particularly for cervical spine, when you have ruled out and you are nearing a diagnosis of a cervical disc disease. And they are called cervical root stretch test. And what they are, you compress a discogenic pain of a cervical disc, pain will increase, or distract the head up, then pain relieves, or turn the head and give a lateral pressure, that is lateral stretch test. So they are the pain root stretch test is elicited or pain increases. But I again emphasize here, must do only when you are sure that you are dealing with a disc disease. Nowadays, to make a diagnosis, these painful tests generally not required, because by other tests you reach to a diagnosis and then you can get investigations done. Now, Edson's test is a thoracic inlet syndrome for a thoracic compromise in the thoracic inlet. And here you turn the neck onto the one side, turn to the face ipsilateral or contralateral side, and ask the patient to take a deep breath. You will notice that radial pulse diminishes. And this is what is a cervical rib or a thoracic outlet syndrome. Now, these are the special tests for a lumbar disease. There are 4 tests. I'm just trying to make them as simple as possible. One is a passive straight leg raising test called Lesigu's test. Other is Bragard test. Some people call it Featherstone's test. The other one is a contralateral SLR and well leg SLR. Now, what is a Lesigu's test? One in an extended knee and extended hip, when we start lifting the limb to flex the hip, at certain point, lifting of the leg, person experiences the pain with which he has come. Here I'm telling you, the end point is not the pain on the back of knee. End point of this test is a pain with which the patient has come. Patient has come with back pain with radiation up to the ankle. On lying down, pain relieves, and when you do an SLR at certain degree, the same pain is elicited. That is straight leg raising test. So the degree between the torso and this is we describe that this is SLR 30 degree, SLR 50 degree, SLR 30 degree. 50 degree, it is almost confirmatory. 50 to 70, it is probable, but 70 degree could be found even in normal person. Now, suppose you are elicit SLR at 60 degree, then bring the limb to 50 degree and then dorsiflex the ankle. If you are able to elicit the same pain, then it is a Bragard test or Featherstone's test. So this is the Bragard test. Now, the rationale of this, that in the root canal, nerve is lying and there is a small prominent disc over there. Now, when you do flexion of hip with extended knee, then generally these roots are stretched or pulled by few millimeter, 2 to 3 millimeter in the spinal canal, in the root canal. And here, if there is a pressure of disc and a prominence of disc, then this nerve may get irritation or provocation because of that. And that's the very basis of SLR, straight leg raising test. Now, when you come down to 10 degree, you remove the irritation of that nerve and then do a dorsiflexion of the ankle. The nerve is again terminally or 1 to 2 millimeter again is being pulled or stretched, and that's how the pain is elicited. Now, these two tests are contralateral SLR and well leg raising test. Now, just imagine there is a huge disc here, and this is the major disc onto this side, and you are doing the SLR of this side. So this root is pulled a little. Now, if on your doing an SLR, one gets pain on the contralateral limb as well, then it is called contralateral SLR. It means there is a massive disc here. So on doing your SLR, this whole dural sleeve is pulled a little, and this nerve, this root is also irritated, and that's what is a contralateral SLR. The other one is a well leg raising SLR. When you do a SLR onto the normal limb and the pain is elicited onto the affected side, then that is called well leg raising test. And these two tests means a massive disc. Now, you've done an SLR, and after the SLR, you flex the knee. So this pain disappears. Now, these are the two hamstring tendon, and these are the tibial and the peroneal nerve. So if you try to palpate them, then they are tender to touch. Then that is what is the bowstring's sign. So this is what is a bowstring sign. Do an SLR. At degree SLR is demonstrated. Flex the knee, that pain disappears, and then you try to palpate on both sides of hamstring tendon. On inside of both two, there is a tibial and peroneal nerve. You just touch it, roll it, and one elicits the tenderness. Now, again, the last is a Mellinger test. Why? because this is one of the most common clinical signs which is abused by the patients. They read from the Google, they come back to you and they just want to take leave because of demonstrating as if they have an SLR positive. So the best way is to make the patient sit, and this patient is sitting here with leg suspended. The moment you extend the leg, so you are the torso and the limb. So this is kind of an elicitation of SLR. So if a true discogenic pain, person will not be able to sit like this, will go back and will try to reduce the angle between the body and the lower limb, as what could be understood by the SLR. So this is a true discogenic pain and not the malingerer. And this is the other way is a slump test. Person is sitting here, bend the head forward and extend the neck. Now this is what is the SLR. And if person doesn't have pain and any of this, then it doesn't have this disease. Now to the SLR Lesig's test, the reverse is a femoral stretch test for a higher disc. Lesig's test generally is significant for a L4-5 disc and 5S1. But for L3-4 disc, it is the femoral stretch test, where you ask the patient to lie prone, flex the knee and hyperextend the hip. If one is able to elicit the pain then in the femoral nerve duration area, then it is a femoral nerve stretch test. The last is a Valsalva test, and Valsalva test is where you ask the patient to increase intra-abdominal pressure without allowing with the closed neck and closed mouth. So you're trying to increase intra-abdominal pressure. By that, because we know that the veins in the lumbar spine, they are valveless. So as a result of pressure, the fluid is pushed into the spinal canal, and all those patients which has a spinal tumors or spinal tumor syndromes, they may sometime present with the typical pain with which they have come. So summarily, when we have finished the examination, we are able to say that by history, we have suspected the broader group of disease. We have verified on physical examination. Now we know the anatomical, that patient has a lumbar disease or cervical disease or a dorsal disease. And we know whether patient has a neurovascular involvement or not. So after this, we move to examination of a neurological examination. Now, in a neurological examination, excuse me. In a neurological examination, what we want to do, we want to rule out or exclude spine affected problem producing myelopathy or radiculopathy, or muscle affected problem as a result of PPRP or myopathy, or a peripheral nerve affected problems. We need to differentiate among three in a case of neural deficit. Now, this is a very important, which you need to understand, that spinal cord starts from foramen magnum and ends at D12L1, while the spine vertebral column goes down below. It means not at the same level, spinal cord and vertebral bodies are correlating. So for cervical spine, it is at 1. So 7 against 7th cervical vertebral body, there is a C8 spinal cord. D1 to D6 at 2. So at D6, it is D8. D7 to D9 at 3. So at D9, D12 spinal cord is there. At D10, L1 and lumbar 1 and 2 spinal cord. At D11, 3, 4. And at D12, lumbar 5 and sacral segment start, and up to upper L1, sacral and coccygeal finishes. And beyond that, all are the roots coming out which will exit at each level. So this is the cauda equina. Now, neurological examination again has to be done in an order. The first two are to rule out intracranial involvement or higher mental function, cranial nerve involvement, and rest of the things we do. So this examination has to be done in this order, because we have to exclude even the higher mental function or cranial involvement as well. Now, these are the various gates. These are neural gates, scissor gait of a cerebral diplegia, where the patient walks with the crossing of the lower limb, or a spastic gait of a hemiplegia, or a high stage gait of a foot drop, or lethargic gait of shuffling gait of a extrapyramidal lesions, or Parkinsonism, or ataxic short shuffling gait of a cerebral etiology. And these are all orthopedic gaits: Wedling or Trendelenburg, antalgic, stamping, knock knee, and short limb gait. So we need to know that whether the person is having a neural gait or a orthopedic conditions gait. Now moving to motor function, it has to be again in the order: bulk of muscle, tone of muscle, power of muscle, reflexes, coordination, involuntary movement, and contracture, if any. So bulk of muscle is important, whether it is wasted or atrophic muscle, which are smaller, softer, and more flabby. And if they are replaced with fibrosis, they become hard and inelastic. So they may be wasted, atrophic, but then they may be soft and flabby, and long standing, they may be even inelastic and hard. While muscular dystrophy, generally bulk has increased and it feels firmer. So this is the wasted, while muscular dystrophy is a increased bulk with a firmer muscle. Now, tone of the muscle, there are various kind of tone. Hypertonia, tone has increased. Now, this increased tone is of two types: is a upper motor neuron type or a Parkinson's disease or extrapyramidal types. So, in an upper motor neuron lesion, it is a clasp knife type. What is a clasp knife? You try to open the knife, there is a resistance, and then give way. So, when you test the tonicity of the limb, you try to bend the knee, there is some resistance, bend at the knee, there is some resistance, and then it gives way. So this is what is a upper motor neuron hypertonia or spasticity. While in a extrapyramidal or Parkinson, there is a resistance, give way, and that's why these are called rigidities. Now, there are certain situations where tone increase is very mild and you are not able to elicit. So in those situations, you do a gender 6 maneuver where you make it like this, where you put both hands in a cliff positions and try to pull them apart. So if there is a milder increased tone by this maneuver, you may be able to elicit hypertonia. Hypotonia, where there is a little or no resistance to passive movement, muscles are abnormally soft. And hysteric, where it doesn't fit in any of these pictures. Now, again, testing of power of muscle is one of the most important issue, because this is the one which is going to help us in defining the level of cord involvement. Now, I would make few statements that yes, it requires practice and patience. You have to practice to elicit the power of muscle. You test the movement and you try ask the patient to perform a movement and you test the strength. Now, movement is tested by comparison with what examiner judges to be normal for a person of comparative build. I think this is a very important statement, because most of the time, whenever I find a patient being presented by a student, they generally say, sir, the power is 3 or power is 4. Now, in an 80-year-old, 70-year-old person, if they are comparing the power of an 80-year person with his power, then it will always be grade 4. But you have to understand that the power or you have to judge by what is the comparative for that patient and that build of the patient. Explain the function to be tested to the patient, and while testing the muscle, always palpate the contracted muscle, because there will be some trick movements for that particular function. Wherever possible, we test the muscle. There would be certain places where testing the muscle is not possible, so we test a function. I'll just show you the example a little minute after. Now, grading of muscle, I think this grading of muscle need no discussion, because this grading of muscle is being taught at every level from 4th semester MBBS onward, that you have to test. You have to test the muscle on the basis of whether there is a contraction, flicker of contraction, no assistant gravity eliminated, against the gravity, with moderate resistance, with the normal resistance. Now, this is what I was meaning, that you are testing the common extensors here. Person is palpating the origin of the tendons, whether tendon is contracting or not, and the power is tested here against the motion, against the dorsiflexion. Similarly for biceps, similarly for the triceps is being tested, deltoid is being tested, long tendons, flexor tendons being palpated. So you have to palpate the particular muscle you are testing, whether the contraction is actually occurring in that muscle. Now here, in some of the, say for wrist, you are able to palpate the radial flexor, ulnar flexor. So you are able to gradually test one by one. Once upper limb is tested, come to the intercostal muscle, you cannot test intercostal muscle onto the grades. You can just simply say whether it is paralyzed or not paralyzed. So if there is an intercostal paralysis on the attempted taking a deep breath, intercostal recession, there is a concavity appears between two ribs, and that is what is a recession of intercostal. While if intercostals are working, then there is no recession. So you can just simply say intercostals are working or not working. For abdominal muscles, it's the Weber sign, and that only denotes when you ask the patient to make contraction of the abdominal muscle possible. If the upper half of the muscle, upper abdomen is acting and the lower abdomen is paralyzed, then umbilicus is pulled up. This information only you can give whether the whole abdomen is contracting or whether the upper half abdominal muscle is contracting. Rest you cannot comment. Spinal extension, again, when the extension is tested, you can palpate the muscle and say, yes, spinal extension are contracting. Similarly, for lower limb, you are testing here flexor, palpating the hamstrings, again, tendo Achilles, adductors, you could see the adductors are being palpated, abductors are being palpated. In the foot, it is possible to test individual muscle. So you can test tibialis anterior, tibialis posterior, EHL, FHL, all individual is possible. Now, after testing the muscle, we come to reflexes. There are deep reflexes, tender jerk and clonus, and superficial reflexes. Now, deep reflexes are monosynaptic reflexes. They test the integrity of afferent or efferent pathway and excitability of anterior horn cell. Make the patient comfortable at ease. Use a soft hammer. Explain to the patient that you are going to give a gentle tap by the soft hammer. You may need to repeat sometime, test several times. What you need to observe whether the jerk is diminished or lost or exaggerated. And here again, you need to not only see the movement of the limb, but you have to see the contraction of the muscle occurring and not the movement of the limb. And if the reflex, you're not able to make sure whether the jerk is exaggerated or diminished or absent, then gender 6 maneuver sometime is required. Now for knee, contraction of the quadriceps muscle is the endpoint. It is best if you do in supine position. However, you can do in a sitting position, but in a paralyzed, in any case, you have to do in a supine position. The root value is L234. Similarly, the other deep reflexes for biceps, C5, C6, triceps, C6, C7, ankle, S1, S2. So these are the various deep reflexes one does. Now, supinator jerk, I remember when the last time this class was going on, one of the students asked what is the supinator jerk. So when you put a blow on the styloid process of the radius, generally there is a supination of the forearm is the response. Now, when there is a lesion at C5, 6, then bicep supination is lost and there is a brisk flexion of finger that is called inversion of reflex. And that is what is a supinator reflex. An inversion of the supinator reflex denotes lesion at C5 and C6. Now, well, theoretically, it is given these are the grading of reflexes, where that absent is 0. Grade 1, it is present as a normal ankle jerk. Grade 2 is brisk as a normal knee jerk. Grade 3 is very brisk. And if it is the reflexes are very brisk, then it becomes a clonus. So coming to clonus, what you have to do is you have to make the tendon taut and give a sudden jerk on the taut tendon. So the response is that one gets a multiple contraction relaxation at the joint. And now, if it is less than 4 such contraction, then it is an ill-sustained clonus, which one may get on the tense or anxious person. Otherwise, it is a sustained clonus, is always abnormal. It is an evidence of upper motor neuron lesion and always has an associated increased tendon reflex and plantar extensor. So sustained clonus is abnormal. It is evidence, it is suggestive of an upper motor neuron lesion. Now there are certain superficial reflexes, and these are anal, bulbocavernosus, plantar response, cremastic, and abdominal. Now these are the root values of these tests. Now anal reflex is where when you scratch the skin, perianal skin, then one gets the contraction of anal sphincter, that is anal reflex. Bulbocavernosus, if you give a tug onto the catheter or you press the glans penis, then one gets the and put a finger into the anal orifice, then one could see the contraction or feel the contraction of anal sphincter. Cremastic, where you stroke the medial side of thigh and one gets the response as retraction of testicles. These two I'm just going to show by the diagrams. So these three are the basic reflexes, and these reflexes are shows whether the spinal shock is over or not. If these reflexes are present and presence of a neural deficit below the lesion, whether it is complete or incomplete, that denotes the weaning of spinal shock. Now, plantar reflex, it is just by scratching by the, not by sharp, but by the blunt pointed object on the lateral border of the sole up to the second metatarsopharyngeal joint. You should not go up to the first. And what one gets is a flexion of great toe and the other fingers in a normal person, while in an upper motor neural lesion, plantar is the extension of the great toe, and fanning of the finger is the response that is called as a Babinski extensor plantar response. Now, in certain situation when it is so hyper excited, then by squeezing the calf, pressing on the inner border of tibia, pinching of the calcaneum tendon, you can elicit the plantar reflex. One has to remember that up to less than 1 year of age in children, this would be a normal findings. Abdominal reflex, here again, we cross 3 dermatomes. We cross 3 dermatomes from on the both half of the abdomen. So all 4 quadrants are crossed by a pointed non-sharp object. And in that case, contraction of the abdominal muscle is elicited. It is absent in upper motor neuron lesion above the spinal level. So suppose if there is a D6 lesion, then these are absent. Impossible to elicit in anxious patients, elderly patients, obese patients, and multiparous women. Now coming to sensory system. Now sensory system are the 6 main sensory modalities. Tactile modality sensibility are light touch and pressure, tactile localization, tactile discrimination. So the presence of feel, touch is appreciated, and touching at 2 different points, tactile discrimination is appreciated. The other one is pain and the temperature. Position sense, recognition of size, shape, weight, and form of the object, and vibration. Now these 3 are posterior column sensation: position sense, vibration sense, and one is able to recognize what is the size, shape, weight, and form of the object. Now, doing a technique of sensory examination is very important. We need to remember the dermatomal pattern of the body. In the upper limb, shoulder denotes C5, lateral aspect of the arm and forearm C6, then the up to thumb C7. So that you need to know the dermatomes, because you have to test in each dermatome. In a dorsal spine, in a thoracic, in a chest, it follows the intercostal nerves up to 6. In the lower abdomen, 7 to 12. Again, the horizontal strips of a dermatome. But in lower limb, again, these do not follow the horizontal strip, and you have to see, because these limbs are rotated, and hence dermatome have a specific area, that L1 around the testicle, L2 upper mid side of the thigh, L3 up to the knee joint, L4 on the medial side of the leg, L5 lateral side of the leg, and S1 on the posterior aspect of thigh, leg, and sole. So that's how you need to remember the dermatome first. You have to test in the dermatomes, number 1. Number 2, you have to move from abnormal to more normal. So move from below to the above, so that one is able to immediately appreciate when the normal sensation is appreciated. It should be done quickly. Just touch, ask, and without repetition. Ask patient must be explained beforehand what you are going to do and how he has to respond. He has to respond a loud yes, no, or whatever way you may see your patient is able to do. Ensure that patient's eyes are closed. And the item used for simple touch, pin prick or temperature, wisp of cotton used for light touch, cold and hot test tube for temperature, and tuning fork for vibration, and certain blunt, sharp things for pin prick, or maybe you can take some pins. Now, after the sensory sensations, we come to position sense. Again, this is very important. You have to shield the eye of the patient. Explain to the patient what are you doing before. Hold the finger or toe on both sides and not from the front and back. Always hold finger and thumb, toe from the side. Explain that you are moving the finger up and down or toe up and down, and what do you mean by up and what do you mean by down. Patient should understand that your up of the great toe is dorsal side and your down of the great toe on the plantar side. And then ask the patient after a closed eye whether your toe is moved plantarward, plantarward or a dorsal ward, up and down. Patient must, and the cooperation and intelligence of patient is must to elicit the position sense. So now we have finished the examination. Now we want to interpret this neural examination. And how to interpret? We need to know whether cord is affected, whether this part is affected, whether cauda equina is affected, whether this roots is affected, whether nerves are affected. This is what we need to differentiate. Now for cord, we need to understand this is the anatomy structure, histological structure of the cord, gray matter, white matter anteriorly. That's how the tracts, motor tracts and the sensory tracts, then further motor tracts. These are the posterior column tracts. So you need to know the mental picture, so that you can elicit which part of the spine is, spinal cord is compressed. Now first, let's clear what is the lower motor neuron below the cauda equina. That is weakness, decreased muscle tone, absent tendon reflexes, muscle wasting, and fasciculation in the affected muscle. So any lesion here in the roots, this all is going to produce, below the spinal cord, is going to produce a lower motor neuron paralysis. Now from lower motor neuron paralysis, weakness and wasting is consistent with the lesion in the spine segment, nerve root or peripheral nerve. So lower motor neuron could be because of spine involvement of the lumbar spine, or could be the root involvement, or could be the peripheral nerve involvement. Now then coming to upper motor neuron involvement, where the vertebral spinal cord is affected. Now here there is a weakness in corticospinal distribution, increased muscle tone, increased tendon reflexes. So you will get increased jerks, you will get a clonus, extensor plantar, and little or no wasting, because it is spastic. So there won't be any wasting. So this is what is an upper motor neuron. So you differentiate upper motor neuron from lower motor neuron. The moment you have decided that this neural deficit is upper motor neuron, so we are sure that it is the spinal cord is being compressed. While if you have made it a lower motor neuron, so we know it is below, is the cauda equina and below. And now how to define what is the label? For label, you need to, we know, we have tested the all muscle. We know each muscle is supplied by which root. So now we know that lower limb is paralyzed, L2 hip flexor is paralyzed. So hip flexor is L2, 3, 4. Now abdominals are contracting. So it means wherever is a highest motor, intact motor is D12 and above. L1 and above, because flexor is paralyzed, L2 is paralyzed. So by knowing this root values, you need to ascertain, you need to define what is the highest motor affected or the first motor intact. And this is what is a simple way of doing it. If abduction is not possible, C5 is possibly affected, C6, 7. These are the, for elbow flexor, C5, 6. So you need to, these pictures are good enough to explain that if one is not able to do this function, and C6 is generally paralyzed, one is not able to do the abduction, adduction of the fingers, then probably T1 is affected. So that's how one makes the affection of the motor segment. Similarly for lower limb, if hip flexor is paralyzed, L2, 3, 4 are affected, extension 4, 5. So that's how one makes a impression what is the highest motor affection. Similarly, by these dermatomal pattern, you are able to decipher what is the highest sensory affection. Now, knowing that highest sensory affection, highest motor affection, one is able to decipher what is the level of cord affection, whether it is the cervical cord affected, whether it is thoracic cord affected, whether it is the lumbar cord affected. Now, when we note that, yes, it is D6 cord, cervical cord is affected, then we note that probably vertebral body should be C5, because we know C6 cord is lying in front of C5 vertebral body, and that you are going to match with your clinical finding, which you have elicited in the physical examination. Now, so from a cord affection, we move a little down. This is the terminal tip of the cord, that is called conus. Now here, if you see it carefully, there is a thin spinal cord and multiple roots coming. What these roots are? These roots are of a lumbar roots coming, which will go out here. So it is a collection of a thin spinal cord and a root, multiple roots. So it is a conus lesion. So whenever there will be a conus lesion, this cord will be affected, as well as these roots may be affected. Some root may be affected, some root may not be affected. So you may get some spare motor or reflex function, because some roots may be not affected. Since the inner part is affected, and here S2, S3, 4 comes out, so one gets a bilateral saddle anesthesia. Prominent bladder and bowel involvement, because bladder and bowel is supplied by S2, 3, 4, this part. So there will be a prominent bladder and bowel function, and there will be impotence. Anal reflex or vulvocavernosus will be absent, because it is these segment S2, S3, 4. They are the root value of anal reflex, vulvocavernosus. So that's how the conus will be different than cord affection and the chorda equina, because in conus there will be a sparing of some motor reflex function. There will be a bilateral saddle anesthesia. There will be prominent bowel and bladder function. There will be impotence, and these anal reflex or vulvocavernosus will be absent. Now, from there down, we come to chorda equina. Now, chorda equina is collection of roots. So these patients will have a severe low back pain of initial disease, whether it is a disc disease or a tumor disease or a neoplastic or asymmetric leg weakness, depending on which root is being affected. And there will be a relative sparing of bladder and bowel function in the chorda equina. As I said, conus lesion, sometime there is a tumor into the conus, mass lesion in the spinal canal, sometimes produces a mixed clinical picture. How does it mix clinical picture? Where you will find that ankle jerk is absent, but knee jerk is exaggerated. It means L2, 3, 4 are spared by this lesion, mass lesion here, but S1, S2 is compressed. That is why it produces a mixed picture of upper motor and motor neuron, and that's, we call it bizarre clinical picture. And this is the characteristic of a conus lesion. So if one gets in the neural examination that there are some jerks, some reflexes are exaggerated, some are absent, some signs of upper motor, some signs of lower motor, then we are dealing with a conus lesion. Now, from chorda equina, we move on to root involvement. Now, root involvement will be single root involvement, whether it is L5 root, whether it is 4 root. So it will be a history of root pain with or without back pain, which is generally found in a disc disease. There will be sensory loss for that root only. It is only medial side of the tibia, L4 segment has a loss of sensation, or L5 has a loss of sensation, and motor loss also in the root distribution. And that is what the characteristic example, L4-5, L5 root is affected, EHL is weak. So this is what is the motor loss in the root distribution. There may be loss of reflex of that very root. If suppose S1 is the offending root, then maybe ankle jerk may be absent. And these patients may have a clinically root tension sign. So that's how the root involvement can be differentiated from the chorda equina lesion. And this root lesion is typically seen in a prolapse disc disease. Now this root have to be differentiated from peripheral nerve lesion, and which is almost a different cup of tea, because each peripheral nerve has a multiple number, a classical sensory loss, classical pattern of sensory loss, classical pattern of motor loss. That will be a nerve lesion loss. So that's how we make a diagnosis of peripheral nerve lesion. So now we move from spinal cord to a conus, to a chorda equina, to a root, to a peripheral nerve. And by these, we are able to differentiate among all four. Now, another important thing is a bladder control. I think, again, I remember last time this question was asked by someone about the bladder control. I think we need to remember two things. Bladder is innervated from above, and bladder retributor muscles, and S234 from locally supplies the sphincter. Now, if there is an injury above, like vertebral fracture and upper motor neuron lesion, now in that cases, sphincters, this is called autonomous bladder, where there will be sphincter will be contracted because the impulse, it's like of an upper motor neuron lesion, and there will be retention of urine. But in due course of time, if we are able to train the bladder in a way that suddenly the sphincter gives way and patient passes urine, and this is what is upper motor neuron bladder, where bladder is distended with a sphincter tight. While if this S2, S3, 4 is damaged, this is called autonomous bladder. Here, the sphincter is also incompetent, and that's why dribbling of urine, or if overflow is the lower motor neuron, where the dribbling of urine will be the common presentation, because here the sphincter has lost its contractility. So these are lower motor neuron bladder. This is the upper motor neuron bladder. So now we have correlated spinal cord localization with clinical localization. That's what we have done by clinical examination. Say, for example, we have noticed that D6 is the spinal cord affected, and we have clinically noticed that there is a tenderness at the dorsal 4, there is a kyphotic deformity, there is all those signs and they are in the vertebral at D4, and this is matching. Neural picture as well as vertebral lesion is matching. So we are more or less sure that we have reached to a definitive diagnosis, the level of vertebral body disease, to suggest a differential diagnosis and suggest the imaging. Now, when you are doing the neural assessment, sometime you need to talk about pattern of spinal cord affection. I told you in the beginning, the cut section, when the whole spinal cord is compressed or damaged, then there is a complete paralysis below, and this is what is a whole cord, complete transverse cord syndrome. While if it is a hemicord is damaged, that's called Brown-Sequard, where motor paralysis is onto the same side, but pain and temperature of the opposite side. This is called Brown-Sequard syndrome. If the central cord is being affected in a spondylotic myelopathy, then it is the pain and temperature tracts which are passing through it, they are damaged, or there may be a lower motor neuron affection of these roots. But so this is the central cord lesions in the spondylotic myelopathy, or maybe anterior spinal cord compression, which generally we get in a tuberculous disease, where one starts with a partial motor loss, and then the further motor loss, then the further sensory loss. And I think if you have read the chapter where I have written March of Neural Deficit in TV spine, this is what I mean, that in 98% instances, this compression starts anteriorly, it starts compressing here, insult of the anterior column, the spinal cord, and to the lateral column. So this is the anterior cord syndrome. So that's what we mean by anterior. Here, the position sense, posterior column sensations are intact. Now, spinal shock, again, a important consideration, important question, important issue in theory and the practical. What is a spinal shock? Spinal shock occurs in a complete spinal lesion, generally after a traumatic event. It is abrupt in onset, complete motor and sensory loss below the lesion. It presents with areflexia, atonia. It is seen with spinal cord lesion with abrupt onset, which may be traumatic, fractures, may be infectious, sudden, sometime because of the mechanical pathological subluxation, dislocation, or maybe vascular damage, or maybe certain transverse myelopathies. It generally lasts for 3 days to 3 weeks time. And in 3 days, how do you come to know that spinal shock is over? Appearance of anal reflex, bulbocavernosus signifies weaning of spinal shock. So if anal reflex has come, bulbocavernosus has come, and if there is a complete paralysis below, there is no sensory and motor preservation below, then it is a complete lesion. If there is some motor and sensory preservation, then it is an incomplete spinal lesion. Again, another question is extramedullary or intramedullary. Excuse me. Now, what do we understand by extramedullary? when this spinal cord is compressed outside by extramedullary compression, or when spinal cord per se is diseased, whether it is because of infection, tuberculosis, or whether it is because of tumor, then it is called intramedullary lesions. Now, extramedullary lesions, where the compression is all from outside, they generally have a root pain or a clinical presentation, worsened by the movement, progressive paralysis, gradual occurrence because the pressure is building, progressive paralysis. They may have a different kind of presentation depending on anterior compression, posterior compression, or side compression, or total compression. This paraplegia will have a sensory level, and incontinence or retention of feces is a late feature. Bladder involvement and incontinence is a late feature. While intramedullary lesions, they are intrinsic disease, urge incontinence, bladder involvement is early, dissociate sensory loss. There will be some, because the spinal cord is directly being affected, there will be dissociated sensory loss. Some tracts are affected, some tracts are not affected. So you may find some sensations are preserved while some sensations are not are affected. They generally have a spinothalamic pain of a spinal nature, and they have a bladder involvement early. So that's how we differentiate intramedullary from the extramedullary. Involvement of bladder, dissociated sensory loss, and spinothalamic pain are the features of intramedullary lesions. Now, again, these three terms which are frequently asked in the examination: paraplegia in extension, flexor spasm, and paraplegia in flexion. Paraplegia in extension is an increased tone of extensor and flexor muscle, but extensor muscle predominates, and hence limb remain in extension. So hyperactivity of extensor reflex, and besides that, there will be a clonus present. Tonic extensor response in lower limb is seen. It's said to be the result of incomplete transaction of spinal cord with predominantly involvement of corticospinal pathways. So generally, when in a tuberculous spine or in any other compression, the paraplegia it starts with paraplegia in extension. Later on, if the compression is of a long-standing or a posterior column disease or a severe paraplegia of upper motor neuron time, then what happens then when we examine the patient, you suddenly notice that patient has flexed both the lower limbs. You are testing the plantar reflex and suddenly patient has withdrawn the limb, or else even it becomes sometimes so severe that you have touched the couch of the patient and patient has flexed both the lower limb. And this is what is called as flexor spasm. It occurs because of exaggerated extensor plantar response. The whole limb is suddenly drawn into flexion, and this is it. What does it denote? It denotes that there is a sensory hyperexcitability, there is a motor hyperexcitability, and it is generally said that this occurs if severe paraplegia of a long standing is there, and on a pathological basis per demyelination of tracts has taken place, and that is why there is a cross connection between the sensory tract and the motor tract. So any stimulus, maybe a touch, anything, the whole motor stimulus occurs and the whole limb goes into hyperflexion. So this is the flexor spasm. Now, if this flexor spasm continues, then patient develops contracture or some contraction, and then patient maintains the limb in flexion, and that becomes the paraplegia in flexion. Patient keeps the limb in flexed position. Transverse involvement of spinal cord generally produce flexor spasm. Exaggerated flexor reflex hold the limb in position of flexion for longer time until they can't be extended. So that becomes paraplegia in flexion. Nowadays, if you ask me, when we were student, we used to get a lot of paraplegia in flexion, lot of flexor spasm. Now we don't see that much because we are diagnosing tubercular disease early and we are treating them in paraplegia in extension. That's why we generally now do not get paraplegia in flexor spasm or paraplegia in flexion. But we as at an institute where there's a lot of patients are coming from different centers, we still get a lot of flexor spasm, and we still see paraplegia in flexion. It is common with infection and trauma or certain intramedullary or extramedullary neoplasm. It denotes complete severance of distal cord from higher center, that extrapyramidal tracts are also severely affected, and that is why flexor tone has has become a dominant force. So when extrapyramidal tracts are spared, it is only the pyramidal system, then it remains in extension. While the compression is such long standing that the extrapyramidal system is also involved, and that is why the flexor tone has become predominant tone. And in such cases, there may be absent patellar and achillic reflex. But the issue with paraplegia and flexion is that they are disabling, painful, and nursing care in such patient is very difficult. So by now, we have taken history, we have done physical examination, we have done neurological examination, we have matched them all. Now we are suggesting making a differential diagnosis, and so that we can suggest investigation. So history, clinical examination, judicious imaging, maybe a sometime repeat examination, clinical imaging correlation. We have to make what clinical diagnosis we have made it. If we have to correlate with the imaging findings as well. This gives a good sound clinical judgment. I think with this, I stop for the examination of spine, and thank you very much indeed for patient hearing. I think if any queries, I can these children can keep on writing and I can reply.
Thank you very much, sir. Thanks a lot for your kind word, and it was a really an elaborative and extensive description of the spinal examination. I hope most of the things must have been clear to all the students. And those who have joined, and for all my delegates, I would just like to say some introductory word for the sir. Dr. Professor A.K. Jain, he has been presently working as a principal of the UCMS Medical College as well as director professor of the HOD department, orthopedics. And he had been IOA president also, and he was IJO chief editor for almost 6 years. So this he is a keen academician, and he has been kind interest in the spine, and especially in the tuberculosis spine. And he has made more than 200 papers, international and national, in his name for the various journals. And now I would request Dr. Sumit Sural, if he can just brief the description of the neurological description of the spine in just few words, so that the students, those who have got such elaborate description, can just sum up the things, so that we can afterwards we can move to the questionnaires.
No, I think Dr. Jain sir has explained it so well in details. I don't think anything else is remaining to be.
Can you summarize few of the points?
So basically, what sir was saying that let's say in a case which is given in the exam, in a neurological case. So sir said very nicely that you have to differentiate whether first it's an upper motor type of lesion or a lower motor type of lesion, and then there are the mixed types, the conus and the the cauda equina syndrome after that. So, and then you have to differentiate from the peripheral. So, and very important what sir said, that once you from your clinical examination get a motor and a sensory, so that neurological examination has to correlate with the vertebral level. So the vertebral level would be where the tenderness is and where the deformity is, and usually it should correlate. And it's very important to do this because you see sometimes there might be skip lesions in tuberculosis. So there are two levels where there are deformity and maybe tenderness, but the neurology may be matching with one level, and so that is the level where you need to decompress. So it's very important for the student to identify and make sure that the neurological level is correlating with the vertebral level. And I think sir covered everything, including the different types of bladder involvement, the automatic and the autonomous, and he covered I think everything. If you want any videos for me to be shown, that's okay. But I think since sir has covered everything, maybe the questions could be taken. That would be better, I think.
Yeah. So, Dr. Sura, we will take the first one from you only. Can you just elaborate the difference between the automatic and autonomous bladder? Because just now one of the student has written to me.
Okay, so sir has explained it. So like it's very simple to remember it this way, that automatic bladder is like a child's bladder. Like, so a child whose myelination has not taken place, the cortex inhibition has not taken place. So it's like a child when when he wants to, his bladder gets full and then he empties it completely, right? So that is like an automatic bladder. So if there is a lesion suprapontine lesion or a lesion in the spinal cord that behaves like an automatic bladder. So that means the bladder gets full and then it releases. However, sometimes there is a difference between the detrusor muscle and the sphincter. So that is known as detrusor sphincter areflexia, right? So then the bladder does not empty completely. The patient tries to empty it a little bit and there's a little bit of dribbling, right? So all these automatic bladders are upper motor type of bladders, which are seen in the spinal cord lesions. And the treatment is usually by either a Foley's catheter or preferably by a clean intermittent self-catheterization. Whereas the autonomic bladder, Sir had explained very nicely, autonomous bladder is like, where there's a lower motor neuron type of bladder, where the parasympathetic, is more affected. So this is also of two types. One is a sensory loss. That means the bladder will keep on filling and the patient will not be able to realize that the bladder is full, right? And then it will pass off urine. Or it is a motor where there is the bladder, the detrusor cannot contract. So automatically dribbling will occur. So this is when the dribbling occurs, so continuously, that is a lower motor or an autonomous type of bladder. Yeah.
Oh, that's great. Jain sir, one question from the chat. It was written, one of the students want to know, so what is the significance of im sign at the level of the lesion and the sign below the level of lesion? Or is the vice versa is also possible?
Come again.
Yeah. So what is the significance of im sign, IMN, at the level of lesion, IMN?
We need
In
to
sign.
motor neuron lesion.
Sorry, it's lower motor neuron. Sorry, it's what's the significance of
element.
lower motor neuron signs? Yeah.
That is okay. It's LMN lesion. Fine.
Yes, that's
Lower motor neuron lesion and upper motor neuron. So upper motor neuron lesion is, yeah. I think. Does he want say full abbreviation or again?
I think there was confusion. He was saying IMN, it's LMN. Okay.
So the
It should be LMN. It should be LMN or UMN. UML. It should be but the PG has written UMN.
So the question
One is
actually
upper motor neuron.
Yes.
Or then the other one is a lower motor neuron.
So
Right, sir.
basically, the question what they want to know is what's the significance of lower motor neuron signs at the level of the lesion and upper motor neuron signs below the level of the lesion.
I don't think this is relevant. See, when you are examining a patient, you first have to find out where is the cord or the neural tissue is affected, and that you can separate out by knowing whether there are signs of an upper motor neuron affection. It means it is the spinal cord level is the affected. And if it is a lower motor neuron types of neurology, then it means it is a cauda equina and below. It is not at the lesion, below the lesion. It's not that. What we are trying to differentiate whether the disease is at the level of spinal cord, upper motor neuron, or below the level of spinal cord as the lower motor neuron. I have given a third where there is a mix of upper motor neuron and that is a little conus lesion. These are the three broad differentiation as far as upper motor neuron, lower motor neuron, and the conus lesions.
Jain, I think
like
the
can I
candidate
add?
wants to ask whether is it possible to have lower motor neuron lesion at the level of lesion and the upper motor neuron lesion signs at the lower level, below that. Is that physically possible? Is it hypothetically possible?
For you say lower motor neuron lesion is at one level.
Yes, sometime. And upper motor neuron lesion at the lower than that.
Sometime it is possible if the disease of the or affection of the spinal cord span to 1 to 2 segment where you can decipher by the root examination that yes, at these 2 roots are lower motor involvement. It happens generally in a spondylitic myelopathies. So where the whole spinal cord below is a spastic, but at this level of affection, you may get clinical signs of a lower motor neuron at the level of lesion.
Yeah, can I just add on to that? Yeah.
Yes, Dr. Sumit, please.
Yeah. So Dr. Jain has very well, explained, right? But if you also, I'll just add on to what he said, that if you read the old Watson Jones, and textbook, and where the description of in the fractures, of the spine. So he says sometimes when there is a along the cord lesion, the nerve root is also severed. So at that level, there could be a lower motor type of picture, right? And of course, sir has explained that if it's a long spondylotic level crossing both a junction between the upper and the lower, where the cord is finished and going down. So that also can give a mixed picture. Another point where we can get a mixed picture, which I've seen, is that when there is metastasis in the spine, you have a skip type of involvement at different regions in the spine, and you can get a mix. Even intervening power is okay in some muscles. So it's a metastasis can have a very bizarre type of neurology. Yeah, thank you.
Generally, we believe that the spinal cord is affected to one segment, two segment, and that very segment should have enough peripheral representation to be elicited as a lower motor neuron concomitant to the distal upper motor neuron lesion. So it depends on which segment of spine. It depends on, are you able to say, suppose mid dorsal spine, two or one segment is affected. It is very difficult to discern a lower motor neuron lesion of D6 or D5. But yes, if it is cervical spine, C5, C6, then one is able to differentiate. So it's a kind of a clinical test at that point of time.
So secondly, the few of the students want to know the difference between the rigidity and the spasticity.
Okay, so as I said, rigidity are found in extrapyramidal lesions. Parkinsonism is the best example, where you try to bend while testing the spasticity, you try to do a particular movement. Say, for example, lower limb, you are from extended position, you are flexing the knee. If you are able to get resistance throughout the whole arc, or maybe some resistance give way, some resistance give way, these are rigidities, lead pipe or cogwheel kind of rigidity. While spasticity, where you get initial resistance, give way, whether flexing or extending, you get initial resistance, and that is what we get in spasticity.
So that is the example of
Just add on to that.
And example is typical tubercular lesion. They are spastic if there is upper motor neuron lesion. That spasticity is a typical spasticity.
Yes.
Corticospinal tract involvement is a spasticity.
So sir has explained it again well, and maybe the student wants to know that there are two terms also involved. One is known as a velocity.
Whether they're interchangeable.
Velocity independent. So basically, velocity dependent. So if you see a spastic limb, the corticospinal tract lesions, like the clasp knife type, so you give a lot of pressure, and there's going to be a lot of resistance, and then suddenly it gives way like a clasp knife. But in that, if you give slow, sustained pressure, then slowly, you'll be able to bend it. Whereas in a lead pipe, you apply velocity with try a lot of pressure, fast or slow, you will not be able to bend it. It will be like a lead pipe, like a pipe which is made of lead. You cannot bend it, no matter what. Or like in Parkinsonism, you may get a cogwheel where whether you do slow or fast, it will just give way suddenly, that type of resistance. So basically, a velocity dependent and velocity independent is also one of the differentiating ways clinically to assess.
So means these words are not interchangeable. So many of the students, they are using it interchangeable words in the exams.
No, not at all. Spasticity is upper motor pyramidal tract, and rigidity is extrapyramidal. The basal ganglia and the globus pallidus, putamen. So that is the extrapyramidal. Yeah.
Sir, one more question. How to differentiate between the sacral sparing and incomplete paraplegia?
I think you need to test the sensation in the sacral segments. Perianal anesthesia, you need to check it. And that's how you need this. You are able to ascertain the sacral sparing.
So if there's sacral sparing, can we call it as an incomplete paraplegia?
Sacral sparing is a sacral sparing, and in the early part, or reappearance of or some examination, some motor power in the distal to the lesion, then that's incomplete. But yes, sacral sparing is in the immediate post-injury period, sacral sparing is one of the good signs to call it an incomplete. So any sensory or motor preservation below the lesion after appearance of bulbocavernosis is taken as incomplete.
So incomplete paraplegia is also a more broad term, you know. Even a Brown-Sequard syndrome would be an incomplete paraplegia.
Yeah, absolutely.
Right. That's it. So there was another question on chat. Dr. Maninder has just now posted it. And I think there was question asked by the students in some Viva question, which bladder is better, UMN or LMN, and which has more complication?
Yeah, so we said, you know, like the infant's bladder, infant, you know, or a child, you know, he is able to empty the bladder. The only thing is that he will go again and again, but he will empty it completely, right? So automatic bladder is a better bladder, right? And it can be, you can put in a self-intermittent clean catheterization so that you can empty it in case it is not emptying completely. Whereas a lower motor will be dribbling continuously and it is more prone to infections, right? Even with the Foley's catheter, it will keep on having infections.
Right. So Jain sir, another question to you.
Upper motor neuron bladder can be trained further. It can further be trained by sometimes even some of them are able to get emptying even by external pressure.
So you can squeeze over the suprapubic area and train and then.
Okay. Sir, another question to you. Explain if vertebral and neurological level are same. How to explain if vertebral and neurological levels are same?
That may be possible. That depends sometime in a long segment disease, and maybe sometime spinal cord has some edema. So it is not necessarily to be mathematically, but it should be very near to. It's not that you say spinal cord is affected at D6 and vertebral localization is coming at C5. It should come as near as possible and depend on the extent of collateral damage which the spinal cord has suffered. So this may vary. That's not a big issue. But yes, your clinical localization of the spine should be clear. And if this clinical neural examination is very near to it, then we take it.
Right.
In fact, children must understand that examiners are not there to get a diagnosis from you. They just want to see how you are trying to reach to the diagnosis, and that's okay. That's okay.
Yeah. Sir, the other one, sir, you have told in Quada equina there is sparing or loss of bowel and bladder. Is it so?
Yes. Not all Quada equina. See, Quada equina lesion will have is a vast spectrum. This may be some motor only, some sensory only, both may be bladder involved. I mean, we call in term of disc, Quada equina, a bladder involvement becomes an acute emergency. But all Quada equina lesions, they do not have a bladder involvement.
Blood involvement,
So
yes.
It is one of the common part of the Quada equina lesion.
Usually,
so you mean the Quada equina?
Yeah, usually Quada equina is because of maybe most common is the large disc, you know, in a young person who is suddenly bent and a large disc has come in. And one common feature of Quada equina is that usually it is symmetrical, like both ankle jerks are absent, bilateral areflexia, you know. So that's why usually they have a bladder involvement. But as sir said, there may be it's a spectrum. You may have bladder partially involved, but usually it's a bilateral, you know, bilateral foot drop or bilateral ankle jerk. So that sort of a picture in Quada equina.
Yeah, no, the thing is, the message is very clear. The Quada equina can be there without bladder involvement. Otherwise, it was being considered normal.
I think, you know, for exam purpose, you should say bladder involvement is one of the very crucial thing. But as sir said, there's a spectrum. You know, human beings is not equal to absolutely, you know, terms and everywhere. There may be some where can be, but by and large, when the examiner asks bladder involvement, bladder bubble and ankle jerk absent bilateral is one of the features that we expect the student to say.
Right.
I think let me put it a little different words. If single root involvement, and more than one root involvement, most of the time in a massive disc and all that, when there are more than one root involved, then by the time bladder is also involved. But single root involvement is again a type of lower motor neuron which is occurring intraspinal and maybe part of Quada equina is involved. So it's a spectrum.
So here I'll
Right.
clarify the single root involvement on both sides, right and left. Now that means a large disc, and then the bladder is likely to be involved.
By that time,
That's
yes,
it.
if both roots are involved, definitely bladder will be, generally bladder involvement occurs.
Dr. Rehan, would you like to add anything? Yeah.
I think if Dr. Sharad and Dr. Vineet permits, I've got a list of 4 or 5 questions which are commonly asked by the students.
Yes,
So
please
what I
go
would
ahead.
do is Dr. Jain can answer first, and then Dr. Sumit Sural can answer. Dr. Sural, can you just have your video on if that is possible for you?
No, unka, I think there's some problem
No,
with this video.
The thing is, then the
Acha, no, it's
bandwidth
okay.
comes
I
down. No?
think
The
his
bandwidth
video is
comes down,
on.
then
No, that's fine, sir.
yeah,
Sir, one of
I'll
the
shut it off.
very common confusions with the students have is what is a knuckle, what is a gibbous, what is a kyphus, or what is an angular kyphotic deformity. And most of the time they are going to get stuck on this the moment they see a case of TB spine. So what is the exact definition? When should they call it a knuckle, a gibbous, a kyphus, or an angular kyphosis? These are commonly used terms.
Okay, so basically, kyphus and gibbous are the general term. Okay,
Okay.
the types of kyphotic deformities are knuckle, angular, and rounded. So knuckle is when single vertebra is involved, angular is when 2 to 3 are involved, and rounded then more than 3. That's generalized like Inschurman's disease or senile osteoporosis.
So from an exam point of view, what is the terminology they should use? Only these 3: a kyphus.
So kyphus is the description of the deformity. It's a kyphotic deformity.
Okay.
Right, and the kyphotic deformities are of 3 types.
Okay. And what are these 3? One is angular.
And knuckle, angular, and rounded.
Okay, so basically they have to use these 3 terms, right?
Yeah, so knuckle is single vertebral, like you have the commonest is eosinophilic granuloma in a child or a central type of tuberculosis. Angular is the commonest is the paradiscal type of tuberculosis that we see, 2 to 3 involvement. And rounded is like in senile kyphosis or Scheuermann's disease.
Yeah, so Dr. Jain, you also agree with what Dr. Sumit
No,
is
I
saying?
think is absolutely fine. The only thing is that the prominence of one spinous process is generally taken as one body disease or 2 body disease where some height loss has taken place and one spinous process has become prominent. If the many bodies are diseased 3, 4, and then there is an angular kind of kyphotic deformity, and generally is absolutely fine. Rounded are those which are in generally senile, ankylosing spondylitis, and all other those kind of things, which has a general rounded kyphosis. But generally, these are the 3 terms described. It's is that well said by Sumit.
Okay. Sir, the other thing when we come from palpation, the moment the student does the direct tenderness test, that means he palpates on either side of the spine and he gets direct palpation as positive. Should he do the twisting test or the direct thrust test or the percussion test, or just
No, absolutely not required. He has already elicited the tenderness. Now, if it doesn't get on the direct tenderness, then he can just put a gentle rotation stress onto the vertebral body to elicit the tenderness. As I said, these physical measures to elicit a tenderness should not be attempted, particularly when we are thinking it to be a destructive or disease of the bone. So direct pressure, twisting is good enough. Both are negative. You can give a gentle tap to have a direct thrust. Anvil should not be preached, should not be done. It's not required nowadays. There are various other methods to make a diagnosis.
So some of the examiners, when the student will do direct tenderness, he would say that direct tenderness is only for posterior sort of disease, while if the disease is more anterior, you should be doing the twisting sort of tenderness.
Fine.
Is that right?
Fine, both can be done together. But
Okay.
certainly thumping and all that is something when you don't have no tenderness nowhere, then you can just do gentle thumping.
Okay. Dr. Sumit Sural?
Yeah, so the point is that you see, if you do not get direct tenderness,
Right.
okay, that does not mean there is no tenderness, right? So you have to do indirect tenderness because most of the tuberculosis paradiscal, you will only elicit tenderness by the indirect rotation, right?
Okay.
Yeah.
So that indirect will be by the twisting test, right?
Yes.
Okay. Sir, again, the confusion is about the Beaver's sign, right? So if you have, if there is tuberculosis of the spine, then some of the examiners will not want you to do the beaver's sign. The others would say, okay, you have to do a beaver's sign when the lesion is probably in the dorsal spine. So what is your take on it? Because they would say that the spine is unstable, the beavers should not have been done, or some would say no, beavers aapne kyun nahi kiya. So kya karna chahiye exactly?
Okay, so
Yeah, Dr. Sumit.
Yes, yes, yes,
Yeah.
yes,
yeah.
Sumit.
So the beaver sign, it is when you are trying to ask the patient to either flex the neck or try to get up, keeping the arms crossed across the chest and trying to lift himself up, right? So
Right.
if the clinical examination, because by the time you are doing the beaver, the neurology, you have already checked the tenderness and the deformity, and you find it's in the thoracic spine, lifting the neck is possible without causing much compromise, then you think you can go ahead and do it. Or you can even, sometimes we teach our students, you can do it isometrically, like ask the patient to attempt to lift the head and you don't allow him, right?
Put
But if
your
you
hand on the
over the
forehead.
over the forehead, yeah, but it's not described, but we say that you can do it that way. But if you're on your clinical examination, you feel there's a lot of tenderness, there's a lot of instability, then you can always explain to the examiner that because of this reason, I have not done the Beaver's test.
Okay.
Yeah, I think this is right, because just let him say that I have not done for this reason.
Right. So
That will
because
be
beavers
accepted.
we will be doing when we are between D8 to D12, right? Others can
D10, D10 to D12.
D10 to D12. Otherwise,
Yeah.
you can always test the
Yeah.
other, right?
Yeah.
So if you think that the spine is relatively unstable, probably it is a good thing I have not done the Beaver's test because I think the spine is unstable. Is that the right answer?
If you can answer it that way and the examiner insists again after that, that still how can you do it? Then you can say that, okay, by flexing the neck or even isometrically.
Okay. Sir, one last question. Sometimes the highest motor and the highest sensory level actually don't match with each other. There is some degree of confusion. So should you give more importance to the motor one or to the sensory one? Because the student again is always confused on that.
See, there are why the motor does not match, because at the thoracic level you cannot sometimes find out the motor accurately,
Right.
because the intercostal recession you may not be able to find out, right? And so and you cannot do the Beaver's test sometimes in a flabby person. Again, the same what Sarat said about the abdominal reflex. In case of multiparas, flabby, obese, you cannot do the Beaver sign, right? So that's why the motor may not be able to, you cannot ascertain the motor properly, and so there may be a mismatch. But sensory is always a very subjective. A motor should always be given a preference over sensory, but if there is somewhere you cannot find out because of these reasons, then you have to take the sensory into account.
Okay.
Yeah,
Dr. Jain?
absolutely. Absolutely correct. This is absolutely correct, that you have to give importance to the highest affection, highest sensory loss. You have to
But sir,
give
motor
relevance.
or sensory, which is more important? Because
No,
motor
it's
is
not a
more
question of
difficult to
motor.
assess.
No, it's not a question of motor and sensory. If there is a motor and if there is a discernible sensory, generally both is together. But there may be a situation where you are not able to elicit lower limb. You are able to tell L2 is the affected motor, but abdominal I am not able to say. Intercostals I am not able to say. I will come back to the upper limb only. So in that case, I will take the highest sensory and decipher the level of lesion.
Okay.
Because that says, sensory affection says that spinal cord per se is compromised.
Okay. Right.
So the take home is that it should be the highest affected level, whether sensory or motor does not make a big difference. Right. Jansen, another question from one of the students. Do a person with quada equina syndrome without bowel and bladder involvement is an emergency? Like normally we take it as a quada equina syndrome as an emergency. If as you said, it's a wide spectrum, it may not involve the bowel and bladder. So still it is considered as an emergency?
Quada equina with bladder and bowel is an emergency. Rest is not an emergency.
Okay. And so another thing, can you elaborate on flexor spasm in spinal cord injury patient? Why there's a flexor spasm? Yeah.
Actually, flexor spasm generally is seen in long-standing neural deficit of a chronic nature, tubercular or malignancy, but flexor spasm is generally not seen in a traumatic conditions. And this is said that this flexor spasm is because of hyperexcitability of sensory and the motor tracts. So that is why any sensory stimulus of any kind sometimes evokes a motor response. And that is what is a flexor spasm. It used to be an unstable spine. It used to be a common feature in tuberculosis. And now with the stability being provided in an early diagnosis, that's why we are not getting a compression of long standing. And it is generally said that it is a demyelination of all those tracts, sensory and motor tracts and extrapyramidal and pyramidal tracts. And that is why there is a hyperexcitability of, and that's why we get the flexor spasm. Generally, in traumatic situations, flexor spasm in a trauma is generally not seen.
All right. Sir, another thing, one of the students wants to know how to differentiate between the reactivation of disease.
Because we have observed even disappearance of flexor spasm over a long time, in 6 months or so, with a proper treatment, proper disease treatment, even they tend to recover onto the flexor spasm.
So I'll just say, like sir explained so well, paraplegia and extension and tuberculosis to start with, then goes on to paraplegia and flexion when the vestibulospinal and maybe the rubrospinal tracts are involved, right? Especially the vestibulospinal, because that has the inhibitory effect, right? And sometimes the tectospinal and all these other tracts. So the extrapyramidal, like what sir was saying. So then the paraplegia and flexion occurs. And when it is very severe and even slightest stimulus, that is the flexor spasms occur. And as sir said, this is mostly seen in chronic disease like tuberculosis, right?
So that means it's quite rare to get it in the acute spinal cord injury.
Yeah.
Yes.
Almost. Jain sir, another question for you. How to differentiate between the reactivation of disease and delayed onset of paraplegia?
Delayed onset? Late onset.
Late on. Like sir, actually, in case of regard to the tuberculosis of spine, we normally call it the late onset paraplegia or reactivation of the disease.
I think let's put it very clear. Any paraplegia coming after initial healing of lesion is taken as a paraplegia with heel disease or late onset paraplegia. Now, this could be a two type where the lesion is still healed and neural deficit has started increasing, and that is truly a paraplegia with heel disease. But it is not uncommon that some of these lesions, they may have a reactivation as well. And that is why the neural deficit appeared afterward is little faster, little severe in comparison to true late onset paraplegia. So there are paraplegia of late onset, a paraplegia with heel disease could be with a healed lesion per se, or could be healed lesion with reactivation.
So clinically they will be the same? Clinically there will be
clinically differentiation would be that these late onset paraplegia with heel disease would have a very slow progression, deterioration of neural deficit. Very slow neural deterioration of neural deficit in a healed lesion. And if there is a reactivation, this may be that they were having some neural deficit for 10 years, but now in last 2 months, patient has developed severe paraplegia. So we anticipate that there may be a likelihood of reactivation of a lesion in a compromised cord already because of severe kyphotic deformity. Spinal cord was already compromised because of healed kyphotic deformity. Now the reactivation disease component has also come in, and that is why this deficit, this deterioration has gone fast. That's the only difference. Generally, not all patients, they have a clinically tenderness and all that. If there is a small reactivation at the apex in an old healed disease, they may have, they may not have. But generally, it is difficult to clinically ascertain, and that's why I have written in almost all locations that all such patients where there is a slightest doubt of neural deficit progressing in a old disease, one must get an MRI quickly.
Dr. Sural, please.
I completely agree. And it's very, very difficult to really find out, even in a a person in a growing spine child, where we, the characteristically we were calling them that because of the growth of the spine and there's an internal gibbous. But actually speaking, whether it is actually because of a reactivation, unless you get an MRI done, a contrast MRI, and look for any reactivation focus, you will not be able to really differentiate clinically. That is absolutely
Yes,
correct on that. I agree.
Dr. Sural, one question for you. Again, I think Dr. Jain has very nicely explained about the contralateral SLRT and well leg raising test. If you can explain them again once more for the student.
Well, the basically contralateral SLR is when the patient is having pain and radiating to one limb, and you're lifting the opposite limb, right? So, and on doing the SLR on the opposite side, right, the pain on the same side starts getting on the side where the patient has the complaint. Okay, that denotes it's a very large disc and it a very high specificity for that, right? So that is what I understand by contralateral SLR.
And the well leg raising test.
I think sir will explain that.
I think
Sir,
I'll
please, can you take up? Yeah, please, sir.
Suppose patient has back pain and radiation to the right lower limb. And if you do an SLR on right side, then while doing an SLR onto the right side, patient experiences radiating pain on the opposite limb as well. This is called contralateral SLR because the disc is massive. So now with the SLR on other side, that whole dural sleeve is moved few millimeter onto this side and the other root is getting irritated, stimulated. So that is the contralateral SLR. Now you put both the limbs down below and now you do well leg. You just do SLR onto the well leg. And then one gets pain onto the presenting side. Then that is the well leg SLR. So it's such a massive disc that that even by flexing the normal well leg, the whole dural sleeve is pulled and it's the root is again irritated and one gets the typical presentation with which the patient has come onto the affected side by doing SLR onto the normal limb. That is the well limb, not normal, well leg. So that is the well leg. These two tests, why I just put it, generally because they denotes massive disc and generally the students sometime being put into a question, well leg, contralateral, and they all get confused. So if you are doing SLR on affected side, if you are doing the SLR on the presenting side, complaint side, and pain appears, radiating pain comes on SLR onto the opposite limb, then it is contralateral SLR. If you do SLR of the normal limb and pain appears onto the complaining side, then it is a well leg SLR because you are doing SLR of the well limb.
Sir, one clarification is better. When you're doing the contralateral test, contralateral SLR, you are raising the affected leg. Okay.
Yeah.
So you not be able to lift it to a large extent of disease. The disease maybe this SLR is positive at 60 or 70. So do you think we'll get a pain on the other side in that situation?
Very uncommon, but it is sometimes elicited. It is sometimes seen.
Thank you.
I think, sir, one last question, and it is from your favorite topic, tuberculosis of the spine. This student want to know the present latest regime of the ATT, and for how many months and when to start the second line drugs. Sir, I just want to add on something in this one. Nowadays, it is said that you cannot start ATT without having the confirmation of the diagnosis. Earlier, we had a trend of giving a trial ATT. So, what is your take on that?
I think the February issue of General Bone Joint Surgery American, the review article is absolutely clears those all airs. In a case of TB spine, ATT regimen is 4 drugs, intensive for daily doses for 2 months, followed by rifampicin, INH, ethambutol for 10 months. So total 12 months. Evaluate the lesion. if the lesion is healed, attained the healed status, then stop ATT. Otherwise, in some percentage of cases, you might have to give for some more months, provided the lesion is responding. Now, this is what is the standard case. Now, if in a case which does not show adequate clinico-radiological response, clinico-imaging response, then in that case, or a new lesion has come up, or sinus has come up, or anything else, any complication has come up, deformity has progressed, neural deficit has increased, all those things, we suspect that lesion is not responding. Now, if lesion is not responding, take the tissue, submit it for histodiagnosis, molecular diagnosis, culture. Now there are various methods available where one of the method will be able to give us the resistance pattern, and then we can start second line ATTs. See, olden time, what we are talking about, there were those cases where we had done histo was suggestive of disease, culture, there was no growth. In those cases, we were putting second line for MDR, not for all those that if the lesion is not responding and I can as well start any second line. No, not at all. And no way any single drug to ever be added just on clinical ground.
So that means, sir, this histo should be done only after 10 to 12 months of the treatment, if the lesion is not responding?
If after 5-6 months you find your lesion is not responding, it has deteriorated, new lesion has come up, or neural deficit has come up, or deformity has increased, lesion is not responding. So anytime around 4 to 5 months, generally we believe 5 months is a good enough time. And by that time, you should be able to know whether lesion is responding or not responding. Take the tissue, submit it for histo, submit it for culture. Histo is to ascertain whether granulomatous disease is there or not. But you need culture, FB smear, molecular method. By that, one should be able to ascertain the drug resistance pattern. Because in a follow-up case, molecular test alone is not important. If the lesion is healing, even if it may be positive for a molecular method. So that is why you have to see that it is an active disease. You have seen that the molecular method demonstrates some resistance. Then we are justified in starting second line treatment. And second line treatment, I again want to say, should be done very cautiously, very judiciously, because these drugs should not be wasted for just by empiric addition of second line drugs.
That's right. Sir, what is your take on trial ATT nowadays? Is it still advisable?
No, absolutely no, big no. Ascertain the diagnosis.
So
can I
you have to.
Can I add on to this?
Yes, Dr. Sumit, please.
Yeah. So what sir says is absolutely correct. However, you see now when we're talking about tuberculosis of the spine, we don't equate everything to thoracic spine. It could be lumbar spine, it could be cervical spine, could be. So when a patient is being diagnosed as tuberculosis spine, if at that point there is a readily accessible abscess which can be aspirated, okay, then you should always take that sample for the, you have either the CB-NAT or the liquid culture, right? Or even when the patient is being before starting the ATT, right? However, now there are a lot of patients on thoracic spine where to get to a material either for histopathology or for the liquid culture, you need to do either a costotransversectomy or anterolateral decompression or some decompression. So that doesn't warrant that you have to do a surgery for removing the material. So if a material is accessible, right, and for even for the joint tuberculosis, if there is a lymph node which is there enlarged, you can aspirate it. So try and get the material at least, so that, because we have seen a lot of MDRs and resistant tuberculosis even in newly diagnosed cases, right? So let's try to get the if possible without having too much of a surgical intervention.
So Jain sir, please.
I would like to add here one thing, that empiric does not mean, empiric is again if a dorsal spine lesion has a classical MRI finding, then it is not empiric ATT. You are starting ATT on clinical imaging ground. If a patient of any disease on MRI shows contiguous vertebral body involvement, intact disc spaces, separated paravertebral shadow, intraosseous abscess, epidural involvement, it is tuberculosis. Absolutely confidently. So it is not empiric ATT. Empiric ATT, patient is low back pain, patient is this, patient has some low grade fever, I'm not able to localize the lesion. Shall I start empiric ATT? No, that is what I mean. You have to make a diagnosis. If you have a conscious diagnosis, then you are justified. And as Sumit rightly said, wherever possible, lesion is accessible, why not have tissue also? And there are many locations where you can just put in a needle in a muscle abscess, and anywhere you can get some tissue and can have a better diagnosis.
I'd just like to add what sir said. Absolutely right. If you look at the RNTCP guidelines, it says that go for a clinico-radiological diagnosis if the material is not available or accessible, right? So as sir said, those features on the MRI and the X-rays, which are and the clinically are correlating, then it is not empirical. Then you are, as for even the RNTCP says, you can start ATT.
Right. I think that is leading to the another question from the student. That sir, in case if the neural paralysis has occurred, then do we need to do the surgical intervention, or we should start the second line of drugs during the treatment when the patient is taking treatment and the deterioration is there, and suppose paralysis has taken place? So then should we directly operate, or should we start the second line of drugs?
I think whosoever asked this question, he should understand first. You have to initially assess your lesion. What is the cause of neural deficit? Is the instability is a cause of neural deficit? Or addition of neural deficit in a tubercular lesion does not mean a drug resistance. We all are teaching that tuberculous lesion, they have in a 30% instances, they have a neural deficit. And these are the indication where you need to decompress the spinal cord. And if stabilization is needed, do the stabilization. So you are treating the spine, treating the disease both together. Mechanical aspect of the spine as well as disease aspect of the spine. Now, second line question only comes when we are suspecting and proving a drug resistance. So then we work for demonstrating the drug resistance and treating it. But before that, we need to suspect, is this patient has a suspected drug resistance case? So that's how we need to analyze this neural deficit. If it has come, it is known then in a tuberculous lesion, some percentage neural deficit will be there. And you have to treat them, you have to prevent them.
I think that means the message is very clear. First of all, with the neural deficit does not mean deterioration just because of the drug resistance. It has to be some maybe mechanical or instability of the spinal cord. Once this thing is assessed, then only we should start second line drug if there's a drug resistance has been documented with the help of some evidence, histopathological. Am I right, sir?
Yes.
So what sir is saying, and it is very common, that patient with diagnosed TB spine is moving around all the time, not taking bed rest, right? And there could be a mechanical instability. So you first find out what is the cause, right? Is it because, on the other hand, if there's a patient who is absolutely on bed rest, taking protein diet, anti-tubercular therapy, and has started improving, and after improving and suddenly started deteriorating, okay, then you will think more in terms something else has happened, because provided that the images also are correlating that it is not a mechanical instability. So you have to look at the patient in toto and try to understand what is it.
That's it. So Dr. Surab, would you like to take the last question which is coming up in the chat right now? When to choose between the anterior decompression and the posterior instrumentation in a tubercular spine?
See, I think the students have to understand one thing. In tuberculosis of the thoracic spine we are talking about now, right? It is majority is paradiscal. So let's talk about paradiscal is the commonest type we are talking about, right? So for a paradiscal, you have to do a decompression which is anterolateral, right? Now, whether you want to do an instrumentation anterior or posterior, right? So those surgeons who are routinely doing anterior transthoracic surgery, it's actually not a very difficult for them. However, you have to understand that doing a transthoracic surgery means if a person who's got a tuberculosis of the lung associated and you're doing on a single lung, right, the patient is likely to go into an ICU, right? So majority of the surgeons who are not trained into transthoracic would go for a posterior instrumentation. Now, because it's far easier to do, right? But the caveat is that when you're doing a posterior instrumentation, do not do a laminectomy for the decompression. The decompression has to be either transpedicular or anterolateral, right? So the instrumentation may be posterior, but the decompression should not be a posterior compression. Yeah.
Yeah, that's a because Jain sir, any further comment? Would you like to add anything?
I think he has very well summarized it. But one thing I would like to just tell for the knowledge at one point of time, because this question nowadays is a non-existent question, whether one should do a transthoracic or extrapleural or do posterior and transpedicular. Because nowadays, very rarely people do transthoracic and it is not required also. But we did at one point of time a randomized control trial between the extrapleural, anterolateral and the transthoracic. And I'm just putting the facts across that out of 10, which were for transthoracic, when we started transthoracic, in 2 of the 10, we were not able to enter the pleural cavity because of old concomitant pulmonary lung tuberculosis. And in that case, the salvage plan was extrapleural. So we moved from, we slotted the patient for transthoracic. When we were not able to enter into it, then we had to do an extrapleural, leaving that, and we just removed the rib posteriorly and went into so the salvage plan was extrapleural anterolateral.
I would just like to add one more thing. Why now most of the surgeons have gone to posterior instrumentation. Another, not only what sir said about difficulty in getting into a transthoracic, but once you do an instrumentation, transthoracic, anterior plating you've done, right? And suppose because of the infection, because of the osteopenia and the infection, the plate gets loose, a second surgery is very difficult. Okay, again, going through transthoracic is if the implant comes loose. So I would advise that for tuberculosis, always go for a posterior instrumentation.
Posterior instrumentation, but the decompression should be anterior or anterolateral.
Decompression, you have to understand, you see, because if you do a posterior decompression and there is a paradiscal involvement, that means what you have done a
blunder.
You have done a global instability, created a and if because of infection that instrumentation fails, this patient has now in a mechanically unstable position, right? So it has happened. I've seen one patient who's been treated somewhere, and the patient was diabetic. Okay, it was a neurosurgeon who had done posterior decompression and a posterior instrumentation. The whole instrumentation failed. The patient's diabetes was uncontrolled, and there was, I think, maybe HIV or something else also. And the whole thing was a global instability, and ultimately patient died also. Right? So you have to be very, very distinct that please do not create more instability by doing a posterior decompression in a paradiscal involvement. Yeah.
Absolutely right.
I think it's nice he highlighted this point. Laminectomy is big no-no to an anterior disease. Instrumentation posteriorly, far away and healthy vertebral body. Decompression anterior or anterolateral by extrapleural. When you are doing everything posteriorly, why not? And you are able to decompress anteriorly from posteriorly side, then why violate chest cavity, thoracic cavity?
Absolutely. Sharad sir, any other point you would like to add?
One question, Dr. Jain, I'll bring you back to the topic of the day, examination of the spine. We talked about Jendrasik's maneuver. So you said it at this, where should the PG talk about this? Because when we learned about this was that we use it in the eliciting of jerks. When patient is not able to elicit, very anxious or not able to elicit jerk, then you do the maneuver. It gives 2 advantages. One is distracts the patient, and number 2, do the reinforcements, and you were able to elicit the jerk. And should the PG speak at that time or at the time of examining the tone, as you
No,
said?
no, I think he can speak at both the time if he has used it. If he has not used it, then it's okay. But generally, what happened that gender sex maneuver is generally required at the time of reflexes, and it is a very rare situation where eliciting a tone you require that maneuver. Very rare. But since we are talking to the student, we have to give the whole picture that there may be a situation you are not able to elicit the tone. And I think I will now I am going to add another things. It is very uncommon, very common in the tuberculosis spine. When patients comes to us, he's little spastic. When we examine immediately, he has plantar upgoing and he shows some clonus. And when the teacher comes to evaluate that student, patient has no exaggerated reflexes and tone is normal, and even the plantar upgoing disappears. Now this happens in some time because as a result of rest for half an hour on the couch while the patient is being evaluated by the student, all those signs have disappeared because the cord edema, which was a transient edema as a result of long-standing movement in a severe kyphotic deformity late onset, was obvious when he came. And after half an hour, it has just waned off. So the students even have to understand that, have to be able to explain, because what he elicited was right. The plantar was upgoing, there was a little tone increase, and in half an hour's time, it has just disappeared. So it happens. But gender sex maneuver, I just added for completion. Tonicity generally doesn't require at that time. You require at the time of reflexes. And generally it is, but just to complete the things that yes, there could be a possibility, then he is not able to elicit, then just, okay, do it like this, ask the patient to, because this increases the bombardment of anti-horn cell.
Can I just add something to this? So what sir said is absolutely right, that sometimes we see such cases, but for the generasis maneuver, since it's been discussed, if you read the Hutchison, it says that it is obviously done when you are not eliciting a tendon reflex and you want to at that time reinforce to elicit it. So the generacic maneuver should be done just at the time when you are striking the hammer, not that you have asked the patient to hold the hand like this, and for around 30 seconds the patient is already holding the hand, and then you're searching for your hammer, and then you've got the hammer and then you're striking. No, it should be done just at the time when you're striking the hammer. So it's better that what I do is I start doing the reflex, and when I'm in the middle of 2 or 3 turns of doing the reflex, I then tell the patient, okay, now you do this, which I've already told him how to do. Right? So it should be done immediately at that point of time.
Right. Sir, one last question, Jain sir, for you. Lethargic gait, you have told about that during the presentation. I think someone wants to know about it once again. That's a neurological gait, na?
Letharism was a disease one time was rampant because there was some mixing of some dals of those kind of things.
Yeah, adulteration, yes.
Adulteration. These were spastic gaits, and these patients used to have a hopping kind of gait gradually while walking, and then they used to become one stick, and then used to become two stick, and they were all kind of a spasticity in both the lower limb. So to move in and maintain the stability in a with both lower limbs severely spastic used to be very difficult. I think now practically this phenomena has gone away because that adulteration and all those things are no longer there. But I think when we were we were student at that time, it used to be many districts in Madhya Pradesh. They were having a huge population of suffering from letharism. But these are severely spastic, unable to move, and for spasticity, they will just kind of a hopping with the two sticks, one sticks in a milder disease, two sticks on both the disease, and then they lost the mobility because of severe spasticity.
Right. So one last thing, we have just mentioned about the hypertonia. So when we are talking about hypertonia, so is it necessary that every time when we are examining and there's a tone is increased, so there could be some kind of rigidity or sparsity will be there in the during the examination?
I think that you will, when you do it, I think if these students, they try on 10 patients, they will understand in a minute that it is a class-night type or it is a non-rigidity type. So it is a matter of practice, which they have to see patients and they have to feel that how does the elicitation of class-night hyperspasticity look like.
Yeah. Thank you very much. Sharad sir, would you like to give a vote of thanks, sir?
Yes, certainly. Well, Dr. Anil Jain, thank you very much for covering the subject so lucidly and so exhaustively. I think that the lots of doubts of PGs must be clear. Not only PGs, even our doubts have been cleared. And thanks to Dr. Sural, ably complemented all the discussions. And thanks our moderators, Dr. Vineet, Dr. Maninder, Dr. Rehan, and all the delegates for giving their time and interacting with us so extensively. Thank you very much.
Thanks, Sharad, for giving me this opportunity. Thanks very much, everyone. Sumit, Rehan, Maninder, and Vinny. Thank you very much. Thank you.
Thank you for
Thank you, sir.
inviting
Thank
me.
you very much, sir.
Thank you so much, everyone.
You're welcome, sir. Thanks. Oh, Dr. Maninder, special thanks to you. Can we leave the meeting now?
That's great. No, we had quite a lot of views today. So we had lots of people today.
Approximately?
About 110 on YouTube and 25 on
Oh, okay. That's great. That's good. That's why there were so many questions was also there.
Yes.
And thanks to the popularity of Dr. Jain and of